Welcome to the latest episode of Lateral Think, brought to you by Melbourne Athletic Development. Melbourne Athletic Development is a sports and injury management clinic based in Melbourne, Australia. To maximise your performance, optimise your injury management, contact the team at Melbourne Athletic Development. As many of you know, Jack and I have a very diverse understanding across multiple areas of practice, whether they relate to sports performance, say for instance with my background in track coaching, or with Jack and his background in yoga practice. We've combined a lot of this knowledge over time with our clinical and sports performance experiences to really develop what we do. And as you know, we love education. So what we've tried to do is take that knowledge and put it into an online learning community. We think this is important because it's an opportunity for people to interact, learn, and upskill as they try to improve the practice of what they do. So if this is something that you would be interested in doing, head to melbourneathleticdevelopment.com.au/education and get an understanding of how you can upskill your current practice. Hello and welcome to the latest episode of the Melbourne Athletic Development Podcast. Jack.
How are you, John?
We're back.
We are?
I'm back.
Yeah, we've got a bit of catching up to do.
We do. What were you thinking of discussing today, mate? You mentioned that you were interested in sort of exploring the idea of evidence-based practice.
I thought I'd open Pandora's box and try and unpack it. And I think, again, we should probably take this from the caveat that you and I aren't researchers, but we are clinicians. And I think when it comes to evidence-based practice, people have forgotten that it isn't just research.
Well, we discuss this often. It comes up in little snippets, and I know that I've gone on rants, and you've probably gone on tangents as well with this. But we thought we'd actually really get into it about what it is, why it's actually important as a foundational feature that underlies some of the philosophy of healthcare, and maybe some of the features that people don't really understand well or where it evolved from, and why it's actually really important for us to not forget its origins, because it has morphed, it has changed a lot, and it probably is corrupting a lot of how people behave within the actual clinical setting.
Yeah, well, I even think of the connotations associated with evidence-based has become solely on research, and we've spoken about this even offline when we've, say, interviewed researchers and they go, oh, well, that is or is not evidence-based, and what they're referring to is purely the research. And I think sometimes we need to take a step back and just go back to definitions of what actually is evidence-based practice, and then we can actually think about, well, how do we implement those different pillars into actually what we do? Because absolutely, one of them is research. But that...
Well, actually, let's start on that. So
yeah.
It's actually not... Well, let's be really, really clear on what the definition is. All right. Do you want me to do it, or do you want to...
I think you probably do it better than I would.
Okay, so evidence-based practice actually came from the work of a physician from Canada named David Sackett in the early 90s. So he started developing this idea with colleagues around how you approach what you use as the influences on making decisions in healthcare, and how that should be applied in order to make sure that you're maintaining a level of quality, but also addressing the problems that are at hand, that are in front of you. And it's made up of three, and they're supposed to be equally weighted parts, right? Those three parts, the one that most people know is obviously they say literature and evidence. However, actually, if you look at the definition originally, it's clinically relevant research. And that's the really important point. Most people leave that out. David Sackett defined it as clinically relevant research. So we'll put that aside for a second to finish the definition, because that's really important. The second part was obviously clinical experience. And what he termed for that, and his colleagues termed for that, was obviously people using the experience that they had from exposure to the profession, being contextually clear, and being able to use what you have from your context and your environment to be able to use when the appropriate situation occurs. And I've got a silly example for you that I'll bring up in a moment about something that is, clinical experience based. It comes from popular from a movie, actually. So I think it's quite a nice analogy for people. And the third one is built around the patient's own values and expectations. And that's really important, right? Because for those people who are aware of, say, for instance, particular religious associations, say, for instance, Jehovah's Witnesses, they won't actually accept a blood transfusion. So it doesn't matter if the most clinically appropriate thing to do is give them a blood transfusion. Because of their religious faith, they won't accept it. And if you go and give it to them, right, you're probably not going to, they're going to be, one, very annoyed with you. You may end up getting, something, the clinical board might be contacted for them to say that you've actually done the wrong thing, right? And the reason is because that's the expectation and the desire of that individual.
Yeah. And that in itself, I think, needs to be really emphasised because... And to be honest, I think I'm even guilty of this myself.
We all are.
Where we love the intellectual process of going through, looking at the research, trying to understand the science, and be able to logically reason what we do. And don't get me wrong, that's an important part. But I often think, and I think this often helps close or identify why some clinicians...
Actually, do you want to tell you a really stupid story?
Well, go for it.
This will tell you about how terrible of a person I actually am.
I already knew that already, but no.
I think you know this story.
Here we go.
All right, so I think people will find this funny, so hopefully it is. So I'm 8 years old, and I'm having heaps of fun. I'm at McDonald's. I'm running around on the playground.
Yeah.
And the playground that I'm on, all of a sudden, I'm running up the stairs, and I slip. And I land directly on my chin and split my chin open, and it's pissing out blood absolutely everywhere. My mum decides, okay, better grab this kid. She takes me actually down the street. She knew that there was like one of those 24-hour GP clinics, one of those big super clinics.
I know what story you're talking about now.
So she takes me, she rushes me down there. I've got, a million McDonald's napkins attached to my chin. And she takes me in, the doctor looks at me and says, yep, no problem. We've got two options. We can either stitch it or glue it, but I think the glue will work fine. It's split pretty cleanly. And I say to my mum and I say to the doctor, look, I don't care what you do as long as it doesn't hurt. Right? So that was my expectation. And the doctor says to me, don't worry, you won't feel a thing. So he gets the glue, he puts the glue on, and as soon as he puts it on, it stings like all hell. I turn around in my infinite wisdom as an 8-year-old and kick him square in the shin. Right? And my mum grabs me and says, what the hell are you doing? And I said, he lied, Mum. Right? He lied. He said it wasn't going to hurt, and it really hurt. So this was in the good old days when you were allowed to smack your kids. I copped a significant smack. And as I said, whilst it's a very silly story, the only expectation that I had set as a patient was that I didn't want it to be uncomfortable at all. All right? The doctor did his job, and he actually did the right thing. And to this day, it's actually held up really well. So the outcome was fantastic. But he hadn't actually met what was my expectation, which was that I didn't want it to hurt.
Yeah.
Now, that might not have been possible, obviously.
No, but it does actually highlight the point, and I know this is something we've talked a lot about clinically recently, where the intellectual pursuit is valuable and important, but I think of something that we've been recently doing with our, say, assessment surveys of when you ask a patient about their problem. Yeah, it's like, how long do you think it will take to get better? And, it
varies.
It varies, but a lot of the time people expect it to get better very quickly, which, okay, I can understand. But, if someone comes in with, let's say... a broken leg is a good example, yeah, or an ACL rupture, and you say, look, this ain't going to be a week period. This is going to take months, you might need surgery, whatever it is. If your expectation of what you think needs to be done, and that might be completely clinically relevant and validated, doesn't meet theirs, you might find that they go, you know what? That's not what I was expecting. you're not going to see
I'm
me
out of
again.
here. Yeah, they didn't do a good job. They didn't answer my questions. Whatever it
Totally.
is, and that's really important because unless you're willing to go and ask that question, what are you hoping to achieve out of this? You may not be aware at all of what their expectations are.
No, and look, I mean, don't get me wrong. In situations where there's like quite a severe injury, sure, you may be able to actually explain, and they go, "Okay, right, I need to." Work on this.
Look, it's always about updating that.
Totally, but I think particularly too with a lot of people who come in with, let's say, long-term back pain. They go, "I want to feel pain relief within 3 sessions," and you go,
That's probably not realistic.
"It's probably not realistic." But I think we need to do X, Y, and Z over a 4-month period.
Are you okay with that?
Yeah, and the reality is, if you don't understand how to actually communicate that, or sometimes too, actually realize, okay, I have this perfect idea of what the best treatment is going to be for you, but that doesn't fit within your expectations. Part of that is about bringing them towards you, but the other part of it is, okay, I need to adjust here. You only want to come in X amount of sessions, or you can only come in once a fortnight, whatever it may be. You can't have this idea that you're going to have this perfect pursuit of it being excellent and not having any... Sorry about that, we just had a short disruption. But going back to my point, it might seem like a relatively trivial thing to talk about of like, oh, of course, like we need to take that into consideration. But how many people actually stop and go, how do I actually navigate through this dilemma when there is that mismatch between what I think is the best treatment plan for this person versus theirs? And that in itself is actually a really important skill. I mean, you might have the best scientific knowledge and the best rationale that you explain to them of, we need to do this and this and this because of these reasons. So what?
Yeah, that's not what they're after.
No, and I think this is a big thing when we need to think about evidence-based practice, that
this is part of it.
That is very relevant, because unless you're someone who doesn't have those constraints related to how often you can access a patient, or potentially things like financial restrictions, or even your example before about certain beliefs and how that impacts their ability to receive certain treatments, you're missing actually a big part of the puzzle.
We'll wait to go to the evidence part because there's some research and some interesting stuff that I think we can discuss there. But the second part that we mentioned was obviously on clinical experience. And I think it's really important that most of us understand that clinical experience is useful, that as we get further on in our journey as health practitioners, we are able to recall situations in which something is relevant and maybe even dispel times when it's not relevant. That brings with it a huge amount of opportunity to be able to call upon that clinical experience.
Well, and I was actually just going to say, as a good example, I think of a presentation you and I did yesterday to a physio group, and the conversation of manual therapy came up. And, I mean, you and I experience this ourselves, and we see it all the time with new graduates, where young physios will come out either as students or as new graduates and go, there's no evidence for manual therapy, there's no point doing it. You talk to any physio with a bit of experience, particularly some of the older ones who have got 20, 30 years where they integrate a lot more manual therapy in their practice, they see that it has clinical value. Now, again, if we want to be very academic about it, you could certainly look at some of the literature of some of the applied literature of using manual therapy as an intervention and see that the outcomes for it are pretty poor. Now, part of that is looking at the actual methodology of the research and how it's done. But part of it is also going, well, if we see that it has a lot of clinical value, but there seems to be limitations or at least different interpretations of the research, how do we actually direct that into what we do clinically? And I think the important thing that people need to remember is you might have the best theoretical construct for why you do something or you don't do something. But if you go to apply it and you go, well, that was a waste of time, do you keep doing it? And I know, again, this might seem like a bit of an obvious thing of like, well, no, of course I want to. It's like, well, why do we then also then limit the conversation of evidence-based practice to go, oh no, but the literature says this. Oh no, but it says that. Or where's the evidence for that? And that in itself is something that I think people need to stop and consider. What actually helps me formulate what I do?
Well, I brought this up with you the other day. And I'm really enamored by the concept of the Lindy effect, which is that the stricter definition of it is something, the duration of something's life is proportional to how long that thing has existed in the first place. Right? So, but in a more sort of general vernacular, essentially, if something has been around for a long time, expect that it's probably going to be around for a lot longer, right? And it's like, so, if a fad sticks, then maybe it's got life. And what it basically suggests is that things that have value will persevere, and you and I disagree, I think, a lot of times on the benefits of things like religious practice, right?
Well, anyway, let's not go down that rabbit hole.
Right. Well, when neither of us are practicing religious people, but
yeah,
I am willing to give this away, which is that if it's lasted this long and it still exists, then it clearly has value. And it's because I have this faith in this idea of this Lindy effect. And I think it's the same thing with something like manual therapy. As you said, it's like whether we like it or not as practitioners, even if the evidence doesn't exist, because maybe we can't, there's obviously caveats on that of like maybe we can't create and generate and develop research that actually is able to identify things in a systematic fashion. That's fine. But if patients like it and patients ask for it, there's clearly benefit to it. They wouldn't ask for something that they feel actually creates zero benefit. So the reason that it perseveres a lot of times in practice is because the actual recipient sees value in it. So it's not up to you to decide whether it works. They're telling you that it works or that they see value in it, right? And I've gotten really enamored with this idea in lots of different areas of like, why do things persist even when on the surface it doesn't make any sense why people still do that behavior, right? And I think a lot of the clinicians who continue to do a lot of manual therapy, even if the evidence isn't there, especially if they're a little bit older, will say to you, even if I don't understand it, even if there isn't the evidence for it, it clearly works, right? And I'm going to support the patient because clinically I see benefit for it. And I think that's really important, right? And that in itself is something that I think when you tip the scales too much towards one area of, say, evidence-based practice, you lose the ability to counterbalance that with the other factors, as we mentioned, the clinical experience, as well as the expectations and values of the patient.
Yeah. And even going back to thinking about defining evidence-based practice, a question we need to ask ourselves is, does research inform clinical practice, or does clinical practice inform research? And the reality is it's both. I'm not saying it's necessarily one or the other, although I think it tends to lean more towards research informing clinical practice.
Let's get to that in a second because I want to finish off on the clinical experience stuff first.
Yeah, sure.
Because I feel like that's a big discussion that will go down a big rabbit hole.
Yeah,
there's two aspects that I'll talk about. I'll give one silly example again, as I mentioned about a movie, because I think it's useful. But there's also another one that I think is important to discuss, which is the expert problem. And in relation to, as we get older, we do have to be careful with biases. But let me tell you a silly story again. Any of you that like 90s movies, maybe even 80s movies, and like people like Michael J. Fox will have seen the movie Dr. Hollywood.
I actually haven't seen it.
Have you seen Doc Hollywood?
No, I haven't.
It's actually a great film. I love movies from that era. Maybe it's the nostalgia of our age, Jack. You are 24 though, so it's a bit different.
Almost 18.
You're Benjamin Button. Anyway, so for those people who've seen Doc Hollywood, there's a scene in it where he's on a night shift. What it is, it's about a young doctor who goes to a small town, as played by Michael J. Fox, and he goes in, guns blazing. This is all done backwards and wrong, and you people are all country bumpkins. And one night he's on night duty, and this kid comes in, blue in the face, unable to breathe sort of that well, and he's feeling sick and all this kind of stuff, and he's doing all these tests, and he's looking and he's going, I think he's got a heart problem. We're going to have to get him to the hospital, and if we can't fix it, I'm going to have to do surgery on him right now, right, sort of thing. And he calls the local doctor, who's this crazy old bloke, and he says, look, this is what's going on. I think we've got to do this and we're going to have to do that. And he just says to him, just give him a can of Coke. He'll be fine. And he yells at him through the phone. He says, get your fat ass out of bed and down here. Like, this kid's not well. So they're wheeling him out. The kid's blue in the face. They're wheeling him out into the street. And just as they get out into the street, the doc comes in his old banger of a car, smoke billowing out of the back of the car, pulls up, cracks a can of Coke, gives it to the kid, and says something to the dad. The dad responds, gives him the can of the Coke. The kid takes it, burps, and goes, "Oh, I feel better already." Right? And he says, "What are you doing?" And basically, what had happened is, in that small town, when kids got an upset stomach, they used this home local brew of, made up medicine that actually turned these kids blue in the face, right? And there was nothing wrong with the kid. And he says to Michael J. Fox, he said, you bloody idiot, you were about to cut open a 6-year-old's chest for a case of diarrhea, right? And what it really highlights is the clinical experience of being in that context, of being in that town and of knowing those people gives that doctor the ability to sum up that situation really quickly and understand that, oh no, this child doesn't have a heart problem. The dad's probably given him this local homebrew medicine and it's caused this issue, and it's actually quite a simple fix.
Just thinking of examples, I think that the other thing that we do is every week we have a meeting where we'll discuss patients. And often, we'll bring up patients where it's like, look, I've got this person, they've been getting, lateral knee pain, they run, I've done A, B, and C, I've looked at their flexibility, I've looked at some strength measures through their lower limb, we've looked at their running mechanics, but they're not getting better. Like, what do I do? And that in itself gives you, what's the process that we go from there? Do we go, well, have you looked at all the research and seen everything that you should have done for lateral knee pain? Maybe that is part of the question. But, as we often find with research, it's like, okay, there's a lot of limitations to what is in what we suggest that we should do. I've ticked a lot of the boxes already of what is recommended as sort of gold standard practice. What to do next? And that actually requires you to think in some type of logical manner of, well, what factors may be associated with this person's problem? And how do I go through that in some systematic and methodical way? Have you addressed potential biomotor abilities deficits? Let's go through that. What kind of things may be associated with developing lateral knee pain when you run, as an example? Have you looked at their biomechanics and looked at it from different positions? What impacts do the mechanics of how they move through their ankle, their knee, their hip, their trunk position influence loading through their knee? Are there factors outside of, maybe related to their training in terms of their training methodology, or even other factors that we know that influence their, say, recovery and response to training that are limiting, say, the turnover of the tissue that's affected? Now, that's really taking a much more of a systematic approach of going, okay, we're using research to think about, are there particular things that are important to look at with this type of pathology or condition? But then also taking another step of going, well, when we look at research, do there seem to be particular things with musculoskeletal problems that are kind of relevant to a lot of different conditions? And the reality is, a lot of the time there is. Sometimes there might be some discrepancies of like, is flexibility really relevant to that particular problem? Has there been much research of looking at active stiffness for this type of issue? But we have to also understand and appreciate that when we look at research, yes, it does give us some signals about what things may be relevant to that person's presentation. But we also need to understand that there are a lot of limitations or gaps. But we can also then fill those in with thinking, okay, when we look at research of understanding the importance of strength, perhaps in different areas of the body, does that give us an indication that strength is a valuable and important thing? And if so, how do we go about assessing that? How do we go about changing that? And I think when you look at it from a much more holistic perspective of seeing, are there common themes or patterns that emerge when you look at the larger body of research and go, okay, we kind commonly see time and again that if we think about the behaviour of tendons, this is how they function and act. And we see that from an intervention perspective, doing things like heavy resistance training or doing stretch shortening cycle to restore its elastic properties may have relevance to any type of tendon problem, whether that's, maybe it's only limited to looking at Achilles tendon issues, but actually has relevance to also rotator cuff tendon problems. And I think that then gives you an opportunity to be able to brainstorm of what things have you done, what things haven't you done, and other things that we need to consider that we haven't even thought about yet. As a clinician, that's a much more valuable thing to consider, and using that approach to be able to think about what solutions we can find for that individual. Because the reality is, and we see it time again, there are going to be limitations within the research, but there's also, I think we need to remember that research again just provides a signal. There's no research that necessarily applies exactly to that patient when you even think about it from the patient-specific
That is why it's contextually important to use your clinical experience to know what is common in, say, the environment that you're consistently operating.
Yes.
If you worked in an environment, and I'm going to come up with a silly example, but say if you worked in a country where a certain genetic trait was very common for some sort of musculoskeletal presentation, then you would have in your mind that would be one of the things that you would explore straight away.
Maybe like hypermobility or something like
that.
Yeah.
I don't know if any of those things cluster within particular genetic or trees or something like that. But I think it's one of those things of like, if you were in that environment and a lot of people in that area develop this condition because of some, say, genetic trait or even environmental factor, then it's more likely that you're going to be clinically aware of that. Even actually as a really dumb example, if you're in Australia and you're a dermatologist, it's probably pretty common for you to be looking for skin cancers. You go to someone who's in, I don't know, a country that's extremely cold and doesn't get much sun, then you're probably not that concerned about skin cancers as a dermatologist, are you?
Well, actually, another good example is, you're a sprint coach. Have you identified over your years of coaching certain things that are very relevant to performing at a high level and certain things that are relevant to injury risk?
Yeah, of course.
And like the things that you develop specifically related to working with that particular population group, because you start to understand what are the physical demands or characteristics of that particular sport, and then what are the particular characteristics that seem to come up as an emerging pattern for those of people who seem to get more injured versus those who don't. And I'm sure that there is some research to help support that or give you direction, but I'm sure at the same time too, through your own experiences, you start to develop an understanding of factors that may not be emergent in the research so far.
Okay, and I think that you bringing up particularly the coaching side of things, I think has jogged me that I think it's really important that we now discuss maybe some of the limitations of an advanced level of clinical experience. And the key one is what people often call the expert problem. Which is that we develop such strong biases not only to our knowledge base, but also to our context and our environment, that we become overconfident not only in our decision-making in that environment, but also in our predictability in that environment. Right? And if you look at the research on things about prediction, particularly in complex areas of healthcare, it's limited, right? There is evidence that some people are good at forecasting things, but it takes a a lot of this work is done by Philip Tetlock, and some people like Tetlock, some people hate Tetlock, but
why is that? Because of his controversial.
No, it's just Nassim Taleb being Nassim Taleb, so I won't get into that.
Yeah, sure.
He calls Philip Tetlock a rat, so. But he calls lots of people all sorts of things. So for a very intelligent man, he doesn't mind picking fights.
It's funny you said I think about a podcast I listened to of Dave Snowden, who have talked about in terms of understanding complex ecology and the things that he said that Nassim has called him before. But I won't share those right now.
Yeah.
He's got strong opinions, clearly.
But Philip Tetlock, and for those interested, it's a very good book called Super Forecasting. But one of his famous quotes that was done from an article, I can't remember if it was in the Atlantic or Time, mid-2000s, was basically his research showed that experts are about as good at predicting as chimps throwing darts at a dartboard. What he's saying is it's not that they can't predict at all, but being an expert doesn't actually often make you better at predicting things. And one of the reasons is that you become very biased towards what you know. And everyone's heard that saying, if all you have is a hammer, everything you see looks like a nail.
Just on that point, because I think that's a useful, while you're talking about this, I think something that's useful to think about is how research and knowledge is dispersed within our profession. Because the reality is, when you think about how research is shared, it's typically through conferences where researchers will present their work, and then researchers presenting their own work in, doing courses or whatever it may be. And when I think about a researcher, they obviously develop very in-depth knowledge in a particular topic.
Yeah, they become an expert.
Totally. I also think it's important to understand too that when they develop expert knowledge, it's often within that subfield within that particular field based on their supervisor. And
we had this experience about half an hour ago, chatting with a researcher, where when we were talking about the topic that his research was based on, it was beautiful. Right? He had so much knowledge and he could keep going deeper, and obviously his knowledge far outweighed ours.
And the ability to articulate the
nuance
logic
of it.
Yeah, absolutely.
Right? The moment that we asked a question that stepped slightly off the path, he was like, and it was funny because I actually thought about this. And you pointed out afterwards that I kind of half checked out, right? I actually was thinking, I actually wish this guy would actually just say, I'm not really that sure.
Yeah.
It's not something that I've explored yet. It's not really an area that I have great knowledge in because we haven't explored it.
And he's a researcher now too, full-time,
yeah,
so he doesn't work clinically.
I wish he had have said that rather than kind of fumbling around for 5 minutes giving us half an answer.
Yeah.
Right? And that's the problem that we all have when it comes to being an expert in something, is that it often, as you said, requires going deeper into that subspecialty of that sub-area. And we get very hyper-focused on what that is. And also, as humans, we are super flawed. And one of the things that we're not good at is, once we do get so far focused on something, we don't see the things around us. Yeah. And that happens, as you said, in the dissemination of knowledge. Yeah. We don't share stuff that is slightly different or maybe even contradicts something that we're saying because we're so hyper-focused on this is what I know and this is what I'm good at and I'm going to share it with you because I'm really proud of what I do.
And that factor of we don't know what we don't know. And I know this is actually something that we've talked about recently.
Actually, I reckon it's, we talk a lot about fascia, as you guys know. And I reckon it's one of the funniest things. I'll put my hand up. When Jack started talking a lot about all of this stuff, I was like, shut up, Jack. This stuff is garbage, right? And the reason that I say that is I had no idea what he was talking about. It was the immediate reaction that we all have the moment someone brings up something that potentially is really important to us but we know nothing about, and our ego gets such a kick in the nuts when we're like, oh crap, I don't know this and I should know this, so I'm going to pretend that what they're saying is absolute garbage and I'm going to shit can it until they've got so much evidence that it's been going for so long that I just say, oh yeah, no, I've always believed in this.
Well, again, I think of the presentation we did yesterday where I was giving the case study and talking about using a certain type of manual therapy intervention to change this person's biomotor output. And someone in the audience, practitioner, said, was that just an
off the cuff comment?
Yeah. And so, of course, it's which is fair. It's it was almost saying a bit like bullshit.
Yeah.
And so I went, okay, look, I think the rationale for it is this. And I went into explaining it, and he looked at me going...
It was actually very funny because the moment that you started actually giving him not only the research evidence, but the depth of physiology he was so confused, and he was like, oh shit, I've got myself into trouble here because I don't understand this.
Well, and what I find amusing about that is that person didn't necessarily say it, but then someone else said, look, I'm not really sure what you just said, but, is it this? Or could you explain it in a bit more of a,
a pared back version, yeah.
Totally. Which is like, yeah, no, of course. But, there isn't necessarily that humility. And I know this is something that you and I have observed when we do have guests, of people who are willing to go, I actually don't know, versus the ones who go, yeah, exactly. And I mean, look, we're all guilty of this. We all have our own biases and ego when it comes to life in
intellectual
general.
stuff, yeah.
Totally. But I think this is, again, an important thing when you go back to research. Researchers obviously develop such in-depth knowledge within a particular, not even topic, but often a subtopic. And that can be obviously valuable in terms of looking at the bigger overall picture. But then I think of some of the limitations about how people present their work, where I do understand there's rigor involved with how you do research, but then how you actually close that gap of going, well, what does this actually mean in the bigger picture? And I'm not necessarily sure if researchers are always the best people to do this. I think
that's where clinicians and that clinical experience is. You can call upon those pieces, as you said, to integrate it into something that's relevant for that individual.
No, completely. And I think some people are better doing this than others. Like I think of someone like, Richard Newsham-West, who clearly has very good knowledge and is a researcher, but has decades of clinical experience of how we actually bridge that gap, and thinking about how we actually, I think often too, it's typically the collective hive mind that can actually put together thinking of, well, look, I know areas about this, you know areas about that, I know this is my experience. What does this actually mean in terms of its clinical application? Because we're not going to ever get one article that goes, great, it's done, we know exactly now how to treat tendinopathies, next question.
Yeah, move on.
This is a thing, we don't have that solution, and to be honest, we may never actually have that solution. Where
do we get onto evidence? Because that opens up the door to an interesting discussion on research and science in itself.
Yeah, what specifically about evidence are you wanting to talk
Okay, so
about?
we spoke about this actually briefly yesterday when we were driving. But I think the biggest thing, and this is the underlying premise that I think a lot of people haven't taken the time to step back and discuss, which is that one, science is a process. And it represents a process of knowledge gain that is being formalized, particularly, it's been going, obviously everyone knows that a lot of these processes have been happening for thousands of years. However, it is but one process of inquiry. It is not the only one. It has a reasonable level of scrutiny placed upon the accuracy of what it does, and we'll get into that in a second. We spoke about p-values yesterday. Excuse me. And there may actually be other forms of knowledge gain that are more useful in certain situations that we don't apply because, as you said, we are not aware to even use these forms of knowledge inquiry in our practice, right? It's not that we don't know of them. I'm sure people have heard of these kind of things. I'll bring them up.
But we don't value them necessarily too.
Or they just haven't been applied in the same way to this kind of setting, because we have generally, at least over the last 200 years, used science as the basis for healthcare application and research and understanding and knowledge gain. Right? More so actually probably the last 50 plus years. But it's been going for probably 200 years in terms of actual research being integrated more heavily into to medical practice. So with that in mind, we then also need to identify, okay, well, if we know that this is one form of knowledge inquiry, what are the foundational features of this form of knowledge inquiry? And one of the things that we discussed yesterday was this difference between inductive and deductive reasoning, and how that actually forms a really big part of the way in which research is conducted. And we're actually seeing that potentially there's been a lot of hijacking of research going on by the utilization, particularly of inductive reasoning. Do you want to explain that a little bit?
I think you're in a better position to explain it than I am.
Oh, really?
Yeah.
So, what we see often now, which I think is different to what people have traditionally seen as the historical basis for how science is conducted. Now, I'm not saying this is right or wrong, but previously a more common feature, and most people would be aware of this if I bring up the example of Einstein. So the form of deductive reasoning is one in which you come up with a hypothesis. Generally, it's a theoretical hypothesis. You put that forward, and then it's either you yourself or you put it out into the world to be tested rigorously. Now, there are different ways of testing that. Unfortunately, it's become much more common for people to search for being proven through verification, which show all you need. And the problem that you have, and we'll contrast that with, you can also prove yourself through falsification, which was the idea of the philosopher of science Karl Popper. And the difference is in one, you're trying to show an instance in which your theory works. And unfortunately, it's actually quite easy to do, especially if you manipulate the way in which you design your experiment. It's actually a lot easier, I think, to prove, and this was Karl Popper's intention with his theories around how science should be conducted, not is conducted, but should be conducted, is that if you use falsification, if you try your absolute hardest to prove that what you're saying doesn't work and you can't do it, then it's probably pretty close to the truth. But all you need to do through a verification model is show once that it kind of works, and then you can claim that it works. So we're seeing a lot of proof through verification, which is a real problem, right? And there's much more practical reasons for why this is happening. The practical reasons are clear, which is you don't get published proving that what you're saying doesn't work. Journals are assholes. Doesn't matter what anyone says, especially if you work for a journal. I don't care. You're an asshole, right?
Well, and the other thing I think just worth mentioning too is journals aren't interested in publishing replication.
They're not interested in publishing replication.
So for people
they often don't pay for the research that they're doing. They then make money off publicly funded research. They often don't pay researchers to do reviewing. They often don't pay sub-editors. Maybe the top editor is getting paid, but they don't pay sub-editors. It's a fucking rort. It's an absolute fucking rort.
I think of a colleague of ours who has done some research in a particular topic and sent it to a journal article to get it reviewed, and the editor said, you haven't included these citations.
No, the reviewer. The
reviewer said, you haven't included these citations. And the citations were all of the same author. As it turned out, it's meant to be blinded, he found out who the reviewer was, and the reviewer was the person who's the author of all these citations, because this person obviously wanted more citations. And that in itself is going, is that really being objective here? Is that really being non-biased?
There are issues significantly with the current... Now, it doesn't mean that it doesn't have value. What I'm saying is there are issues. And so if you don't identify these issues, you can't then...
don't put it on a pedestal of thinking that is an absolute of which all decision-making should come from.
Right. And this has been, we'll get to it, but this has been debated, these kind of concepts. There's a researcher, he's now dead obviously, this was in the 50s and 60s, he wrote a number of books, but a major one, he was from the University of Stanford, or Stanford University, a guy named Thomas Kuhn, who spoke very heavily about how science is conducted. And one of the biggest things that he criticised in his book it's considered one of the major parts of the philosophy of science research and theory, and it's about paradigms and paradigm shifts, is very much exactly what you said. He really rejected the idea that science should be put on a pedestal, because whilst it is a level of knowledge inquiry that does have a level of scrutiny placed upon it, and there are structures and processes put in place to impart quality on the way in which it's conducted, it has many flaws. And you need to recognize that, because otherwise you will take it verbatim that what these people are publishing is true or close to the truth with high levels of confidence, when maybe that's not the case.
And that in itself, in terms of taking it verbatim, is not understanding how research is interpreted, and hence why you have different experts actually having contrasting opinions about a particular topic or area of research, which I again think just highlights that this idea of absolutes of this is entirely factual or not needs to be held up to scrutiny, because we do see variability in research findings, in terms of you might have a similar research question that's been done multiple times and see differing outcomes, and we see that all the time when we think of our area of research, and more importantly, people who are interpreting it going, well, I came to a very different conclusion than you did, which highlights in itself that there is it's open to interpretation.
I realised I didn't finish that story on Einstein, but basically Einstein put forward his theories, general relativity and special relativity in 1905, and then 1915 or something like that. I'm probably getting those dates wrong, so apologies for those people who understand it better than I. But there was an experiment that was conducted in 2018 that finally was able to prove what Einstein was saying, because we didn't have the technology to prove it. Right? And that demonstrates that idea of deductive reasoning, where he's put forward a theory, it makes sense on paper, the mathematics hold up, but we don't actually have a way of proving it yet. It took 100 years, and he was proven to be correct 100 years later. And that in itself, I think, highlights that difference between what we are mentioning here, which is often with this inductive reasoning, it goes in the opposite direction, where people are now doing a lot of research, and what you just mentioned allows us to start talking about statistics, right? A lot of people are doing a lot of research where they go on fishing trips. They design, and you can see through it often. There's a million different variables that they're measuring, and you can kind of identify, like, they don't actually have a hypothesis for what they're looking for here. What they're doing is they're just going to test a whole heap of things in a population over a period of time, and then we'll see if any of them stick and there's any correlations.
Well, and that's the thing. And often if they do have a hypothesis, it's like, why are you looking at that variable? Like, is that really clinically relevant? But it's probably often reflective of where they get statistically significant results.
And so the idea of inductive reasoning is one in which you take observations from what you're experiencing in your environment, and then you start to develop theories based on the data that you've collected. Right? And on the surface, that doesn't seem unreasonable. However, the problem is it's easy to hack what you see, and it's easy then to start making up theories, right, post that support what you've done, without actually going through the process of testing what you're doing. So that's happening a hell of a lot, and I think it's causing major issues. And you, as I said, you can see right through it if you're paying attention. If you look at a clinical, even sometimes it happens in RCTs, where they measure all these variables, they do have intervention in place, and they kind of give a loose hypothesis, like, we think this intervention will do this. And then all of a sudden there's this really elaborate discussion of, like, oh, and it's doing this and it's doing that. And it's like, you weren't expecting that. You just found that, and now you're somehow kind of retrofitting it to your hypothesis. One
thing you mentioned then that I think also requires discussion, this is something I've actually spoken about with some researchers at Lateral, is how we actually structure studies to test a hypothesis or look at an intervention. Because most people who are in healthcare know that randomised controlled trials are seen as the gold standard type of primary study. And like, when you think about its inception, it was really about testing pharmaceuticals. Which makes a lot of sense, because you need randomisation, so people are allocated to an intervention or a placebo. You need a control group. You need to ideally have blinding, where the participant doesn't know what they're receiving.
You poke them in the eye with a hot poker.
And also the researchers don't know what they're receiving. And when you think about, say, drugs, it's very easy, because it's like, here's the pill, the placebo versus the actual thing looks the exact same. I don't know what I'm giving you. You don't know what you're getting. It's really up in the air then. And again, there's clearly clinical value to that because it allows you to be very rigorous with thinking of, is this actually having a physiological effect or not? I often think of, is there an issue with translating that type of model of study to, say, conservative management of what we do? Because when I think about what we do, particularly if you're doing, say, an exercise intervention or manual therapy, there's no ability to blind
it's very difficult.
A participant. So they know if you're putting your hands on them, or they know if you're giving them generic exercise versus, knee-specific loading for patellofemoral pain. You, as a clinician working with them, know exactly what you're doing too. So there is no blinding in that situation. I think the other really important thing, though, too, is when we apply an intervention, well, hopefully, as a good clinician, you're thinking about, okay, I'm going to give you an exercise intervention. How am I structuring that? Am I giving you a generic protocol? Am I going, okay, let's have a look at some flexibility. Okay, you've got a deficit in hip rotation. You've got a reduction in ankle dorsiflexion. What interventions do I need to apply? Do you have any strength deficits throughout your kinetic chain? Okay, I've identified weakness in here, here, and here. Do I identify and continue the process of going, okay, I've collected a series of data and identified 4 or 5 modulators I think are related to this person's presentation. What interventions do I need to apply? And then more importantly, how do I actually configure those interventions to the individual? Am I just going to give you a generic thing of just do 3 sets of 10, body squats? Well, for a 28-year-old elite athlete who plays rugby and has been squatting for the last 15 years of their life, is 10 by 3 bodyweight squats going to apply an appropriate mechanical stimulus to induce adaptation? Probably not. Yet again, we have to also put up for scrutiny how research is done, because typically whatever intervention is applied is in a very generic nature to a very generic population group. And then I often think about, this isn't really reflective of what we do in clinical practice, or at least it shouldn't be. So, and I've put forward this to researchers, like, can we actually do a better approach? And I know there actually is some research coming out now of going, look, we're going to collect data on these variables and we're going to provide interventions specific to where we see deficits, which I think is obviously much more reflective, and all of a sudden you're going to have variability then in the intervention that's applied. But this is not a bad thing. People obviously may put it up scrutiny of going, well, how do we know?
They didn't control what that intervention was.
It's like, well, hang on a second. We're trying to actually replicate something that is reflective of what happens in the real world. And I think that's a really important thing that people need to understand. And it helps you to understand some of the limitations with research. And I think a good example of this that we've talked about a lot before is, say, stretching, where people will very quickly criticise stretching.
It doesn't work, yeah.
It doesn't work. And it doesn't take much when
it's not good for you, or it's not going to make a difference.
Totally. It doesn't take much when you look at the methodology and you go, oh, they just got them to stretch for 10 seconds? Like, is that going to make much difference? Or they just got them to stretch until they felt the first bit of discomfort and they didn't progressively overload that. Is that going to actually induce enough mechanical stimulus? Yeah. And again,
it'd be like saying do a squat with, as soon as it feels a little bit hard, and it's like, oh well, it felt hard at 10 kilos.
Totally.
Their 1 RM is 200 kilos. And like, oh, but I noticed it at 10, so I'm just going to stop there and just do 10 kilos only for my intervention, weight.
And look, it's one of those things where I think a lot of people go, oh, yeah, like, okay, of course. But then part of it goes, well, how do you know you've actually applied an appropriate stimulus for that individual? Are you actually applying appropriate training principles or collecting appropriate data to see, am I applying enough stress to create the adaptation that I'm seeking?
And I think that, that's where, as I said, you go back to the start of this discussion, and we identified that what was in the clear definition of evidence-based practice is clinically relevant research. So when you read research, you need to see, does it fit the population and the intervention type and the context and the environment that is suitable for you? If it doesn't, it's probably not clinically relevant. And so if an intervention is done on 15-year-old female soccer participants for Achilles tendinopathy, you probably can't apply that to an 85-year-old grandmother. it's a different population. Even if the intervention that was applied could be applied, right, because it's not outside of the bounds of their capability, understand that that may actually not work in that context. Doesn't mean, I'm not saying don't try it, but don't run in with confidence thinking, oh, this is going to work because it worked with his 15-year-old soccer team. It's not maybe clinically relevant for someone who's 85 years old.
I think one other important thing to consider is what kind of reasoning do we use based on what we're doing specifically? And what I mean specifically here is we can typically be a lot more logical and procedural when we think about a diagnosis, which I think typically we need to be. We need to have clarity on going, what are the things or clear signs and symptoms associated with this particular injury or pathology? And that typically is going to be pretty similar. A good example of that is something like a hamstring strain. We know that there are usually key indicators. I mean, we've got to think about different types of hamstring strains, but for your more classic high-velocity sprinting one, is there a mechanism? Is there tissue capacity deficits? And so on. But then the process that we use for understanding why did this person get injured requires a very different reasoning process where we need to use a different framework. Well, at least I'm of the opinion. And of course, this is
our opinion because it's...
Totally. All of this is our opinion. But a different framework of going, I understand what the injury is, but now I need to understand why this person got injured. Because this person might be a footy player who plays in a team with 30 other players, and he's the person that's got a hamstring strain. What is it about that individual that led to him getting a hamstring strain, but none of the others? Now, again, we can obviously look at the research to get an idea of what are signals or factors that we seem to be relevant to the development of a hamstring strain injury. But I also think we need to take it a step further to go, what data have I collected that I can use to create a hypothesis for why this person developed an injury? And that certainly may be related to the biomotor abilities of the hamstring muscle, but it also may be related to other things as well. When you think about, 6 months ago that person injured their ankle, do we actually see some deficits around their ankle and calf that are affecting loading through the kinetic chain? Or this person's got a really stiff hip because they played soccer for 5 years before they went to footy. How's that impacting the function of their hamstring? And this allows, again, it's a cliche thing to say, but individualization of management. But unless you take that process of understanding and creating hypotheses on the data that you collect for understanding why this person got injured, you're going to be stuck in that process of going, here's the one-size-fits-all approach, and, hopefully I'll get some people better, but it doesn't also work well when you have people who get re-injuries.
I think we've been going a while, so I think we'll end it on a quote that I think I'm going to paraphrase, so it's not going to be correct, but from our good friend John Ioannidis in a beautiful letter that he wrote, and it actually was published into a research article, but a beautiful letter that he wrote in prose to David Sackett in 2005, I believe, that said evidence-based practice has been hijacked by research. And it was of his opinion that it was important that we protect the foundations of evidence-based practice, particularly for the benefit and outcomes of patients.
And actually, a good resource for people who are interested in understanding evidence-based practice and potentially limitation to how research is done, to look up some of John Ioannidis' work.
Yeah, well, I think his paper that's very facetiously titled something like 95% of medical research is all wrong or something is the highest cited medical paper ever almost.
Yeah, indeed.
Yeah. All right. Thank you very much for joining us. We hope you've enjoyed this.